So I'll just share with you some of the information that I sort of think is important in this area. Since yesterday, I have not gained any disclosures. So, and this is sort of just a quick outline, just a quick epidemiology, focus on some of the historical, important historical steps in the management of metastatic renal cell carcinoma. The CARMENA trial, and if you don't know that, you will by the end of this talk. The bulk of this will be talking about clinical scenarios for cytoreductive nephrectomy, and touching upon some future areas that I'm excited about, and conclusions. So this is just quick sort of filler slide kind of thing. So yesterday was much more this localized group, and these patients do so well. Localized disease, 5-year overall survival well exceeds 90%. The regional group, and we talked a little bit about this earlier today, anyone with nodal disease, regional nodes, or certainly T3 disease, these patients have a distinctly more challenging natural history. But what our talk today will be focused on is the distant disease, patients who have disease that has extended beyond the kidney. And this is a big problem. You can see the dramatic drop in 5-year survival for this group of patients. So it seems like I like timelines since I used that all yesterday. But what I mentioned yesterday was about Charles Robson and the establishment of radical nephrectomy as a standard of care for renal masses. To go over in slightly more detail, early vascular control, en bloc removal of the kidney and the adrenal gland, and extensive lymph node dissection were the tenets that were associated with a radical nephrectomy. I think these are clearly debatable points now, specifically the adrenal resection as well as the lymph node dissection. And be happy to talk about that at some other time. But regardless, this approach, radical nephrectomy, was established as a standard of care for all renal cell carcinoma in the late 1960s. So in the early 1980s, though, cytokine therapy was introduced. So interleukin-2, interferon alpha were found to have some activity with regards to renal cell carcinoma. It wasn't dramatic, but it was definitely better than chemotherapy. 3%, 12% versus 3%. Doesn't sound great, but it is 12%. It's definitely bigger than 3%. So to be very clear, chemotherapy and hormone therapy were deemed essentially ineffective for renal cell carcinoma. What was effective for these more advanced cases was high-dose IL-2. It had about 15%, 15 out of 100 people would respond to this. And of those, I think it's a little bit generous to say 5%, probably a little bit lower than that, would actually have a durable, complete response, like all their disease would melt away. The trade-off was that it was incredibly toxic. These are patients who, during the course of treatment, were in the ICU. They had such severe vascular leak syndrome and all these other adverse effects that it was critical that they were healthy patients. You could not take someone who had terrible comorbidities and expect them to do well with this. The alternative was interferon alpha, which was also effective. 10 or 15 out of 100 patients were found to respond well to this, but it only had a modest survival benefit. But the good thing is it wasn't nearly as toxic as a high-dose IL-2. So with these treatment options, was there really a role for cytoreductive nephrectomy? And as we discussed yesterday, clinical trials, randomized clinical trials are kind of our go-to. So there were two, the SWOG 8949 and the ERTC 30947 trials. And these were essentially identically sort of structured trials. You had biopsy-proven metastatic renal cell carcinoma in generally healthy patients that were surgical candidates, no prior treatment, no thrombus above the hepatic veins, adequate renal and liver function, and no other concurrent malignancy. These patients were randomized to cytoreductive nephrectomy followed by interferon alpha or just interferon alpha. The primary endpoint was overall survival, and response rates were also assessed. So as you can see here, this is a combined result from these two trials. And essentially there was, with the interferon alpha compared to, or the cytoreductive nephrectomy seemed to add roughly about 6 months survival benefit. Now, that doesn't sound like a tremendous amount. If you look at statistics, you can say, oh, there's a 31% reduction in the risk of death. It sounds kind of better that way, right? But regardless, this was found to be kind of the thing that worked. Maybe not worked great, but worked. And so cytoreductive nephrectomy was established as the standard of care for metastatic renal cell carcinoma. Now, why would removing the primary tumor help these patients? Any thoughts from the audience? Yeah, I mean, probably. There are some interesting thoughts, though. I think my favorite one is that it would eliminate this immunological sink, because this idea is that the cytokine treatments are working on sort of the immune system, RCC being an immunogenic tumor. So this idea is that somehow the tumor was sequestering the lymphocyte and macrophages and immunoglobulins, that they wouldn't be able to go fight off those metastatic sites of disease. Other people thought that maybe by removing the tumor, the primary tumor, it would prevent the secretion of these cytokines that would also inhibit the body's ability to fight off this disease. And then I think probably one of the most reasonable ones, it would, by removing the kidney, would limit the development of new biological clones, new sites of metastatic disease. I think that's, sure. But I think that's quite reasonable to say you're just reducing the tumor burden. Maybe the disease can be more easily combated when there's less of it there. Regardless, this era was then kind of called the cytokine era. And because of these two trials, cytoreductive nephrectomy was the standard of care. And this was how it was supposed to be. And this is kind of where I was in the very early part of my residency. This is like 2004 when the combined data came together. But since that time, there's been so many advancements. This is just one diagram, highlighting these cellular pathways, the hypoxia response pathway, the mTOR, or the mammalian targeted rapamycin signaling pathway. And with this better understanding, then better therapeutics were developed. So the cytokine era sort of gave way to what's now termed the targeted therapy era. And here, this is not a exhaustive list, but these are some of the more notable agents that were developed during this time based on the understanding of the pathophysiology that was occurring with renal cell carcinoma. So naturally, with these improved agents, the question still comes up, is there a role to remove that kidney? And the first large-scale efforts to really answer these questions were using larger databases. So this is the IMDC dataset, the International Metastatic Renal Cell Carcinoma Database Consortium, retrospective analysis, nearly 1,700 patients. And as you can see here, if you had a cytoreductive nephrectomy, the median overall survival was about 20 months, whereas no cytoreductive nephrectomy is about 9.5 months. So cytoreductive nephrectomy was associated with a 40% reduction in the risk of death. So our group looked at the same question with the National Cancer Database, a bit of a larger cohort, but really we're finding very similar findings. 17.1 month overall survival with the cytoreductive nephrectomy compared to 7.7 months only with targeted therapy only. So cytoreductive nephrectomy here was associated with a 55% reduction in the risk of death. So these are the data that were available in sort of the mid-2000s or mid to late 2000s. And actually 2010s, take that back. So based on this information, it's pretty obvious. Yeah, we should be taking out everyone's kidney, right? So cytoreductive nephrectomy is associated with overall benefit when combined with targeted therapy. This is great, but what we really want, as stated multiple times, is to have randomized controlled data. And that's where the CARMENA trial came into play. And now I don't speak French, so I'm not going to try to say what this, pronounce this, but the CARMENA trial, as you can see listed there, was a phase 3 randomized non-inferiority study comparing nephrectomy plus sunitinib versus sunitinib without nephrectomy as first-line therapy for patients with metastatic renal cell carcinoma. Yes?
It's the third trial now. You're showing that it didn't have nephrectomy alone. Is that just so well known? What's the survival with nephrectomy alone? Is there a reason they had on the third arm?
Yeah, I mean, those patients didn't do real well before, in the prior to the cytokine era. So from Charles Robson's late 1960s establishment to the 1980s, those are not good days for metastatic renal cell carcinoma.
You showed like 50% 5-year, but what's the median survival?
No, it's,
Oh, wait, I think it's months.
I mean, back before we had all this stuff, it was almost nobody lived a year.
Because you were showing 7 months with one of the arms.
Right, that's with one of the systemic agents.
Oh, I understand.
Yeah.
But is it possible that nephrectomy alone is as good?
No, I can't quote that. I can't cite the citation for you, but no, it's not. Sadly, we would love it to be, right? It's like, no, but I mean, systemic disease requires systemic therapy. I mean, that's one of my points later, but that's why if you take out the kidney, people don't die of what's in the kidney, people die of what's outside the kidney. So there are these case reports of people seeing spontaneous regression of disease once that's removed, but that's why they're case reports, because you can't rely on that. So this study was very similar to some of the other studies looking at overall survival. So the Carmina trial was published in 2018. Again, it was a non-inferiority study, nearly 8 years of enrollment, 450 patients were enrolled. The target was set 576, so it's a little bit weak in terms of its power. About 50 months of follow-up and 326 deaths occurred. So I've mentioned non-inferiority a couple times, basically from a mathematical perspective, looking for a hazard ratio less than or equal to 1.2 would mean that sunitinib alone is not worse than cytoreductive nephrectomy plus sunitinib. And much like the figures from yesterday, the top right of the screen is a better place to be. So what you can see here is that not only was the hazard ratio less than 1.2, it was well less than 1.2, actually less than 1. So that's why sunitinib alone is more to the right of the screen, meaning that those patients are living longer. And just by the way it was set up, I like to be very strict about my wording and saying this study shows that sunitinib is non-inferior to cytoreductive nephrectomy plus sunitinib. And now some of the data people have looked at and have rendered some sort of criticisms on this, one of which is that this is a cohort that was enriched with a lot of poor risk patients. So nearly half of patients fell into the poor risk category. And those patients, many of whom we never really wanted to operate on anyways. So maybe this was just a reflection of the fact that we were randomizing all these really bad players, if you will. Now, if you look at the median overall survival benefit, it was 0.89, but if you broke it up into the intermediate and poor risk, if you just looked only at intermediate risk, that group was also very much trending towards sunitinib alone having a better outcome, but we're going to call it non-inferior based on how the study was set up. One of the other big criticisms of the study was that it was using sunitinib, which I'm not sure how familiar you guys are, but that's not something that we're using very routinely these days. Even in 2018, when this came out, a big criticism was like, we're not even using this as first-line therapy. So at this point, because we have a whole host of different therapies, and looking at this, we have a whole host of newer therapies known as immuno-oncology, and then there are a lot of combination therapies between the two, IO-TKI therapies. So in many ways, I view the Carmina trial as a reflection of the improvement in systemic therapy. There's been just a much better understanding of this disease. And instead of having response rates in the 10 or 15%, we're seeing response rates closer to 40%. Yeah, we'd like it to be higher, but this is a dramatic improvement compared to where it was. And the median overall survival in the best case scenario was, in the 20-month range, but it's 26 and even greater for a larger group of patients with the targeted therapy. So as I said before, I think systemic disease requires systemic therapy. So no matter how great we are at surgery, if we can't treat those sites of metastatic disease, these patients will have problems. So again, I will use my very strict definition or based on the non-inferiority study design, cytoreductive nephrectomy based on these data should no longer be considered the sole standard of care treatment for patients with metastatic renal cell carcinoma. So when this clinical trial came out, I wrote with my colleagues an editorial, which is, does Carmina mark the end of cytoreductive nephrectomy for metastatic renal cell carcinoma? And sort of just to kind of line it up, this is the pre-Carmina sort of algorithm. You had kidney cancer, the kidney is, or metastatic renal cell carcinoma, the kidney's in place, and you can get that kidney out, you get that kidney out. If the patient can tolerate surgery, if it's not going to cause great morbidity, get that kidney out. And then you can consider metastasectomy, and then at the bottom of that algorithm is systemic therapy. Post-Carmina, you have metastatic renal cell carcinoma, kidneys in place, you could consider either cytoreductive nephrectomy or systemic therapy. And then after that, metastasectomy or systemic therapy. And so this editorial was focused in many ways, as this talk is, on which patients we should consider for cytoreductive nephrectomy, given the data that exists based on Carmina. And interestingly enough, a good friend of mine is a surgical oncologist, and he mentioned this phrase, I guess this famous phrase in surgical oncology: biology is king, selection of cases is queen. And the technical details of surgical procedures are princes and princesses of the realm who frequently try to overthrow the powerful forces of the king. But really, biology is king, and I think selection of cases is very important. So I, in my editorial, highlighted 4 clinical scenarios that I thought would be quite reasonable, despite the information of benefit from sunitinib, that cytoreductive nephrectomy remained an extremely valuable treatment option. So the first being palliative surgery, to palliate these patients. Now, palliative surgery is relief of symptoms and suffering caused by cancer or other life-threatening diseases. The classic triad, which is not that common, is flank pain, gross hematuria, palpable mass, very frequently associated with more advanced disease. But as many of you know, there's paraneoplastic syndrome. Patients can have hypertension. Frequently you'll see weight loss, fatigue, and in more severe situations or more rare, the Stouffer syndrome, having liver dysfunction. And I don't care what medication you have, it's not going to be faster, in my opinion, to alleviate some of these issues than surgery. So I do think that palliative surgery can address pain and hematuria, can minimize paraneoplastic syndrome, and improve the sense of well-being. So number 2 is consolidative therapy. So consolidative therapy is used to eliminate residual cancer cells that may be left in the body after initial therapy. So for example, this is a patient who had widespread disease in both lungs and arising from the right kidney. Received systemic therapy, and everything in the lungs melted away. By taking out this remaining site of disease, he should be free of disease. He should be NED at that point. And one of the most compelling reasons to pursue this approach was actually another clinical trial that was conducted at the same time as a Carmina trial, which is called the SURTIME trial. And one of the reasons, SURTIME standing for surgery timing or surgery time. And one of the reasons that we don't really hear about this is because while the targeted sample size was 459, we only had 99. So it's severely underpowered. So this does not get the sort of the press that Carmina does. But you can see that there is a very similar patient selection, clear cell renal cell carcinoma, healthy patients, resectable mass, no prior therapy. But here we're looking at 2 arms, both of which have surgery, but it's like, which one comes first? The surgery followed by sunitinib, or sunitinib followed by the surgery? And the primary outcome was progression-free survival, which I'm going to tell you right now, there was no difference for. But their secondary outcome was overall survival, which interestingly enough did show a difference. So even though progression-free did not have a difference, the overall survival did. So these patients who deferred surgery increased their overall survival by roughly 15 months. Honestly, these are the best numbers I think we've heard thus far, right? And of course, it's couched in the knowledge that this is such a small sample size that some of these numbers may really be somewhat inaccurate based on just the small sample size, by chance, if you will. But I would argue that consolidative therapy, if you can remove the remaining disease in the body after some systemic therapy, it makes a lot of sense. It's also, the Certine trial showed that those patients who had systemic therapy first and then underwent surgery actually had pretty low morbidity. It wasn't like these tumors were all scarred in, which I think that they can be, but it wasn't preventing patients from successfully undergoing surgery. Like I said, ideally, we are achieving a complete surgical CR, surgical complete response. Yeah.
A question about that trial. So the people who went on systemic therapy, there must have been some who never went to surgery. So
Exactly.
how many of those were there?
That's a great question, which
Everybody else looked better, right?
yeah, I have another slide about that. It doesn't actually, it's not directed at the Certine trial, but it's a general statement about that. So I'd imagine somewhere in the 15 or 20% range. But yeah, you're absolutely right. So the people who couldn't make it there, though I think it was a intent to treat analysis, so they would have still been considered in that group. Now, the third group is the non-clear cell group. Remember, only clear cell renal cell carcinoma was included in the trial. And those pathways, those cellular pathways that were discovered were for clear cell renal cell carcinoma. So, but we know that clear cell is not the only type of disease that we see. It's the bulk of our renal cell carcinoma. But we have papillary, we have chromophobe, collecting duct, renal medullary. What about those patients? Are our systemic therapeutic approaches even useful at all for that group? And if not, then I would argue that we should be doing a biopsy, identifying those patients and maybe considering surgery for them. The data at that time was somewhat limited. This is from one trial looking at metastatic papillary, and there was a slight survival benefit, but as we all have seen here, retrospective data, and this is retrospective, by the way, but from IMDC, it's not the same as a randomized controlled trial. But yet, I'm still arguing, at least in 2018, that papillary, chromophobe, collecting duct, renal medullary, we should think about biopsy. I think I mentioned yesterday that I questioned biopsy for small renal masses, but I'm actually a bigger fan of biopsies for the larger tumors that could be metastatic. And that's because I would favor a cytoreductive nephrectomy for that group. And then the last category or last clinical scenario is oligo-metastatic disease. These are patients with limited disease. If you have disease like a large renal mass, that represents like 90+% of your disease, maybe a very small site of disease in your lung, perhaps we can just address all that disease. And maybe that's all they need. Very limited disease beyond the kidney. This would actually address Craig's comment, like surgery. We can just take care of that. If we can address, it's called metastasis-directed therapy. If you can just address all the disease, then maybe that's all you need. So ideally, we're not just taking some metastatic disease, we're eliminating all that oligo-metastatic disease. So again, we have these agents that we were relying on in the early 2010s, but all these immuno-oncologic agents are really have become incredibly popular, not just in kidney cancer, but throughout the oncology world. So is there a role for cytoreductive nephrectomy, given that we have essentially moved beyond just sunitinib as first-line therapy, but all these combination therapies? So many, if not all, the trials for IO therapy, and this is not an exhaustive list, compared these new agents to sunitinib. So if sunitinib was good, and these seem to be better, and they've all been approved based on their superiority to sunitinib, then of course it makes sense that they would be even better than sunitinib, right? It is important to know that some of these have achieved complete response, but it's really only in the 10, 11% at best range. But still, we're talking nearly 9 out of 10 patients who have this disease, who get, who get treatment are not being entirely cleared of their disease. And it's also interesting to note that these very notable trials that have led to approval of so many different agents, most of them had cytoreductive nephrectomy in the trial. These were not tumors that were just sitting there. Only maybe 20 or 30% of patients just had the treatments. And based on conversations with my colleagues in medical oncology, some of the people who had the best responses had their kidney removed. So it's not a clear cut kind of thing, but I can tell you that the whole field shifted away from, let's call it a reflexive cytoreductive nephrectomy. Like the immediate response was, can we get this guy to surgery? It shifted away from that because of Carmina. And you can look at that based on trends. So Carmina came out, like I said, in 2018. And prior to that point, roughly a third of patients with, in the National Cancer Database, a third of the patients with metastatic renal cell carcinoma received cytoreductive nephrectomy. But you can see these numbers sort of have been gradually decreasing. So it's been a while since 2018. We had a whole pandemic and everything in between. So these were the areas that I favored. But how about today? What data have come about in the last 5-6 years? So, this is a study that looked at 317 patients with metastatic renal cell carcinoma. And this is a very busy slide, but this is highlighting all the symptoms that these patients have. And I'll just draw your attention to the overall population. Any signs or symptoms, 2 out of 3 patients had some kind of symptom that's been attributed to renal cell carcinoma. It's highest among those with poor risk disease. 80% of those would complain of some kind of local or metastatic specific or general symptom, for example. But with palliative surgery, these patients, we're seeing some benefit in terms of the more global symptoms, moderate benefit, I would argue, but local symptoms, boy, the vast majority of them, this is like hematuria and pain associated with tumor there. This is much better. And these authors concluded that a large proportion of patients with metastatic renal cell carcinoma are symptomatic, and cytoreductive nephrectomy has a positive impact on symptomatic status. I think anecdotally, I've seen this myself. Patients will come in with tremendous tumor burden, bleeding, pain, just a sense of not feeling well. And I have seen patients who don't ultimately do well, but at least for a period of time following surgery, they clearly look better. They obviously have to recover from surgery, but they can do better. So I still believe in this one. Actually, in fact, I think this is the easiest sell. Someone comes in with tremendous pain, you're going to give them a treatment that will take weeks or months to have benefit versus a surgery that, yes, challenging in many cases, but is can be extremely effective. And a big part of my approach to this is I basically only did laparoscopic cytoreductive nephrectomies. I was really all about minimizing one's morbidity so that you could move quickly to systemic therapy. So it's very doable. I think that there's some people who think that a cytoreductive nephrectomy has to be done through an open fashion. I very much disagree with that statement. And patients can recover relatively quickly. So what about the second category, consolidative therapy? Now, in this systematic review, which included 2 prospective randomized controlled trials, that's Carmina and CERTIME, 4 phase 2 prospective trials, 6 retrospective population-based cohort studies, 3 single institution and 4 multi-institutional. And so it's a wide swath of things. So in terms of overall survival, deferred or consolidative therapy versus upfront therapy, it consistently favored deferring surgery until after systemic therapy. And if you compare it deferred to just systemic therapy alone, it was even more compelling. And I think this goes to your question, about 60 to 84% of patients proceeded to cytoreductive nephrectomy after systemic therapy. So the most common reason for not actually undergoing the surgery is because they had progression of disease, which actually is, in my opinion, not a bad thing to know. What we discussed in our editorial was that this approach gives us sort of a litmus test as to whether or not this patient would even benefit from surgery. I mean, we've definitely taken patients to surgery who will then have this cascade of terrible outcomes and then never get systemic therapy and unfortunately die of their disease. those patients, I don't know that I ever really want to take them to surgery. But those who do respond, they seem to do well. The patients who actually respond to systemic therapy have a good response. We can eliminate all their residual disease. I think it's quite reasonable. And this is the way of sort of assessing that group. So about 60 to 85%. Another rationale is really the trauma and the consequences of surgical trauma. There's cortisol release, there is this activation of immune cells. There's a whole cascade of catabolic sort of and inflammatory insulin resistance, really, which can lead to several weeks of immunosuppression. I'm very much convinced when patients ask me, if the cancer is exposed to oxygen, then it spreads everywhere, right? Like, I think that's a bunch of crap, but maybe the trauma of surgery may allow, if there is a real immunosuppressive component to keeping cancer at bay, we might be limiting that ability in the process of removing the primary tumor. So hence maybe wait until after the sites of metastatic disease are more managed, then go after the cancer or the primary site of disease. I think it makes more sense. So our group participated in a multi-center study. I think actually the vast majority of cases were mine. We looked at patients who had metastatic renal cell carcinoma and underwent systemic therapy. These were immunotherapeutic options. Average time was about 8 months, and consistently we saw benefit. Decrease in tumor size, decrease in tumor thrombus, renal score was reduced, radiographic staging showed improvement, pathologic staging was also improved. I think that consolidation is really where I have done in the last several years nearly all my cases after systemic, that and the palliative. But I think there are still a lot of questions. How long do we give systemic therapy for? Now that study was a mean time about 8 months. But if we're seeing improvement, do we stop at 8 months or do we just keep going? Typically, we just keep going until we see a plateau in improvement, but that's not really been studied. To what degree of response? Is it until there's no disease left, or is it, at some point where you could do the cytoreductive nephrectomy, maybe metastasis-directed therapy? And what happens afterwards? We get all this disease out, they've been treated, maybe they had an excellent response, no disease outside their kidney, we take that kidney out. Do they really need to stay on therapy? So these questions are being asked right now and being investigated, but I can tell you in 2024, it's still a very debatable point. And it's very much sort of nuanced by the medical oncologists at our institution. And that's kind of why I want to emphasize that this whole thing really needs to be multidisciplinary care. You can't really be just I'm not giving systemic therapy. I don't know if you guys are, I suspect not. But if you talk to Sandy Srinivas and she's like, yeah, the patient is doing really well, and then you get them back and talk about surgery and then hand them back to medical oncology potentially to continue therapy. That's typically how it is right now. So I am an enormous believer in this approach of deferring surgery, waiting until it represents consolidative care. And we've had patients do really well in this approach. How about non-clear cell? So this is a busy slide, but notice at the top it says VEGF and mTOR inhibitors. Really hard to see. This is a whole wide range of tumors: papillary, chromophobe, sarcomatoid. And this is objective response rate. And these are like 8%, 10%. At the bottom, probably because of lenvatinib, it was 25.8%. But most of these do not respond well. But specifically MET inhibitors for specifically papillary renal cell carcinoma, that's metastasized, some of these respond really well. I mean, that's the basis of their pathology, right? Some cases, the MET positive have a 50% response rate. But then going to immunotherapy, again, this is just a wide range of non-clear cell tumors. These studies were all showing 20, 30% response. I think this is the area which is going to continue to improve. And you can see the most recent NCCN guidelines. It used to be like clinical trial, and then maybe cabozantinib. But now there's a whole host of other recommended regimens. And it's because of all the advancements for non-clear cell. Yes, they're based on clear cell, but some of them, like the MET inhibitors, are based on a real understanding of the pathophysiology here. So in terms of, do I want to biopsy these guys and figure out who is non-clear cell and take those guys to surgery? Actually, I don't. I'm not pushing that too much anymore. I think that this is, I root my colleagues on to find better and better therapies so that I can come back on that consolidative front. And then finally, oligo-metastatic disease. Soon after Carmina was published in 2019, a couple of European guidelines still immediately published, the results of Carmina and Cytokine should not be used to abandon cytoreductive nephrectomy in patients with low volume metastatic disease. The EAU also perform immediate cytoreductive nephrectomy in patients with oligometastases when complete local treatment of metastases can be achieved. And small studies are suggesting that if you can have complete metastasectomy, it's your best outcome versus incomplete metastasectomy, and certainly the worst is no metastasectomy. So in this scenario, if you have a tumor that goes to the lung, you can treat this with surgery, as we alluded to. A lot of this is now being directed towards radiation, SABR, like the stereotactic ablative radiation. But regardless, if you can do cytoreductive nephrectomy, metastasis-directed therapy to eliminate all the disease, this is what we spoke about earlier today. M1 NED patients. This is the Keynote 564 trial. This is the group that has responded best to adjuvant pembrolizumab specifically. The hazard ratio is 0.28. These patients, all patients in all groups seem to have progression-free survival benefits. And now there's evidence of overall survival benefits, but this is the specific group that did the best. So there's compelling reason to use this approach and then hit them with adjuvant pembrolizumab thereafter. The other way is maybe delaying therapy. And at least in this very small study with 40 patients, about half of patients were able to delay their systemic therapy for about a year or so. So for oligometastatic disease, I'm still a fan. I think that this is a group that, we should treat. I do get concerned that by the time I see a patient, maybe they're not oligometastatic at that point. So I try to get them to the operating room as quickly as possible. So to sort of conclude this, in 2024, I'm sort of looking at these clinical scenarios to palliate symptoms, to consolidate after successful systemic therapy. Remember, that's a litmus test. Those patients who do not do well, I'm okay stepping back and kind of second line, third line, whatever line therapy to go and perhaps not offering surgery. But then oligometastatic disease, I think that's also another group that we can focus on. But of course, randomized controlled trials are what we want. So there are three that I'm aware of. The Nordic Sun using deferred cytoreductive nephrectomy and synchronous metastatic renal cell carcinoma using Nivo and Ipi. Cytokit, which is using also Nivo, but in this case, cabozantinib. And then the PROBE study comparing the outcome of immunotherapy-based drug combination therapy with or without surgery to remove the kidney in metastatic kidney cancer. And this is using a whole host of different IO agents. Results supposedly coming in as early as 2025. We'll see. I'm not that confident. But, this is still an incredibly active space. I'm sure you know of patients. We talked about belzutifan earlier, our HIF-2 alpha inhibitors. There's another agent that's in that class that's coming out as well. But what I get sort of excited about are some of the other options that I've been able to be part of, some of these immunotherapeutic options. The one that I wanted to highlight is we have this NeoVax trial, which is new vaccine. And this involves doing first a removal of the kidney. And then this is then used to identify specific isotopes or neoantigens that will then lead to specific vaccines that will then be injected back into the patient that can then treat some of the metastatic disease. So I think that there may actually be a bigger role for cytoreductive nephrectomy if some of these advancements do come to fruition. So in conclusion, I think, like I said, the Carmina trial highlights all the pretty impressive advancements by our colleagues in medical oncology to come up with better systemic therapeutic agents. Systemic therapy is non-inferior to cytoreductive nephrectomy. Personalizing the treatment is really where it's at, in my opinion. Palliation, consolidation, and oligometastatic disease. And again, it's still a pretty active field. We'll see future drug developments with those vaccines or with the HIF-2 alpha inhibitors really change things. But the key is to personalize care, individualize. So personalization over protocolization, and multidisciplinary care with medical oncology is key to that. So going back to that, that surgical oncology, you know, biology is king, but selection is queen. So thank you so much for your attention.